Arya, Akansha, Vijay Kumar, Atul Kali.
Good evening, everybody. Thank you all for joining us today. Thank you so much for patiently waiting in spite of all the technical glitches. I present to you Dr. Sheetal Vijay. She is going to talk about pediatric case taking, and I hope everyone learns and takes home. Oh, you're already at home, so take home wonderful messages and learn a lot more today. Thank you so much, and over I'll give the mic over to Dr. Sheetal. Yeah, Dr.
Thank you,
Sheetal.
Dr. Rashmika. First of all, I thank you and Mr. Is this echoing?
No, no, no. We can hear you perfectly clear.
Okay, done. So thank you so much, Dr. Rashmika and Mr. Karthik for this opportunity. So without much ado, so yeah, before you take home whatever I can, I think I want at least to take to your clinic whatever I'm trying to say, and let it stay with you for for I don't know however long you practice and improvise it from here. This is just a start, and whatever it is, wherever you're learning in this webinar or other webinars, take it as a start, and try to improvise and go deeper and deeper, so that we can learn better and give more better treatment to our patients on the long run, right? So yeah, let's start off. So my name is Dr. Sheetal Bidri, for whoever did not know me. So today I'll be talking about pediatric case taking. So a lot of requests were there for how do we start off with a child? How do we, take case for a child? So that's why I thought it's appropriate for students and the first few years of first year of PG scholars, or fourth year, final year, when you have pediatrics as a topic, and you don't know how to go to a pediatric OPD and you don't know what to do. So even if you're observing your PG scholars in your particular OPDs, at least observe what and know what they are trying to do in the clinic. So if I may have to say, um, a case taking, or the method of any physician is no less than a detective, and the only difference is one is seeking for a disease and the other is seeking for a crime location. So if we need a proper, a thorough kind of a case for our prescription, we need to go in deep into every case, and in a way that we can picturize the whole thing, like how a detective would do into a crime scene. So if I have to say it in a few words, it demands a skill of not just a doctor, but also a little bit of lawyer and a detective. So, and also a little bit of a judge who can finally come to a picture like what is right and what is the need in this particular case. So, if you could say a pediatric, especially a pediatrician, would need to be a lawyer, come detective, come judge, and more so you have to be vigilant. You have to look for what is best in your sort of case. So what does a good pediatrician require? First, like how Hahnemann in his aphorisms also, he always mentions some requisites for the physician, requisites for giving a particular treatment. So like that, what are the requirements for a good pediatrician? So firstly, he has to be a good observer, like how Hahnemann has told. That becomes a key feature in a pediatric clinic, because more or less in the pediatric clinic we tend to deal with beings who cannot express themselves. So you are relying more on the observations what you are going to get in the clinic. So more or less you could say how we could correlate veterinary medicine, but over a period of time, it gets easier as the age progresses in the child. So, because we are dealing with the child, we have to be friendly. Unless you are friendly with the child, have a pleasant face, have a warm welcome, and not feel too, don't intimidate the child, and you can avoid that white collar anxiety in the child. and by just being friendly and a little smiling on a smile on your face, and not being too formal, like directly get into the stethoscope or directly getting too into all the technical stuff. So the child gets scared immediately. So you need to be relaxed, need to be informal, need to be very aram se, like very laid back with the child. Give the child the time. Give the child to open out and help him to express himself. So as we know, as homeopaths, every child is unique, no matter, no doubt. We have to respect their uniqueness. But when it comes to a case taking, we have a performer, we can stick by it, but you do not have to go hard and fast by this particular step. You can start wherever. You can start however the child is, coming to you. Probably when it is a newborn to, to toddler, it's more with the, attender who you're going to talk to. Probably when it's a slightly elder child, he can come talk to you. You can greet him. You can ask him about how his day was. So you can start off anywhere. So that is the beauty of pediatric case taking, because every case also is unique, because the child is unique. So every case taking also becomes very very unique with every child. So let's just start off. And what I like to say is, the pediatric case taking is nothing, it's not rocket science, it's not difficult, but there's just an addition to what we usually do it with adults. So if I may say, you can remember it with the abbreviation MAIN, MAIN. So the additional thing what we have in the pediatric case taking is mainly the milestones, which is supposed to be given the most importance, and the anthropometry. Anthropometry is nothing but the measurements, or how they are growing, how what is their height, what is the weight. So the measurement what we do in the child, that is the anthropometry, what it requires, and immunization. So we'll go in depth with all of this. Immunization is another, and nutrition. So these four things, you can remember it as mean. So if you finish taking a case, in the end, ask yourself, have you done the main thing? So have you asked your MAIN? So this would just be a hint, but to go overview, from the basic, we started off from basic. Like, even if a student is hearing this particular webinar, I want you to be able to take a case in such detail that even your examiner can be very impressed by you. So in a pediatric case taking, so we start off with the basic information. We know that we have to take the name, age, sex, and because of the different diseases that may form in other ways. So here, important is in pediatrics is the informant. Who is an informant now? Informant is not a person who's accompanying the child. So he is basically informing you of the child's situation, or the illness, or the disease. So he becomes a key feature in the case taking of a pediatric case. So over a period of time, like say from say 5 years, or if the child is 5 years plus, the child also can start informing their problems, and what they are observing, and what they think they are feeling. So the informant initially becomes very important. Then later on, even the child can start informing the particular cases. Who is the informant? We have to be very vigilant if that informant is reliable or not reliable. So depending on that, because you have to be a good judge. Like I said, you have to be a judge in the case taking of this of the child. And socio-economic history also is very important, especially in India if we are taking a case. So here, uh, depends on where the child is living, the housing conditions, or if there's too much overcrowdedness, or this polluted areas, people with recurrent respiratory illnesses, or who are sensitive to the damp environment, or sensitive, or they're living in near the sewage area where the drinking water is contaminated. They're coming up with recurrent diarrhea, recurrent abdominal pain. So that becomes also important when you get to know their socio-economic history. So Then you directly dive into what is the presenting complaint. So, as we know, in a chronological order, in the patient's name or the informant's own words, we start taking the case as it is. Then we can go into the details of the presenting complaints. What we usually forget is the negative history. Negative history is something what we have to take to rule out any other illnesses which we can suspect in the early stages of the life. And the onset, duration, and progress also helps us to know the cause and the duration, what has happened during it, and what is the progress of the disease. And if there are any other symptoms involved in that particular system or even any other. And history of etiology, we know that as homeopaths, we know the importance of etiology, the ailments from what we say, be it a physical or a mental, anything that becomes a important pointer in the case taking. And also any history of complications. Probably the once you take up the ODP of any case, we will start knowing what are the complications and how it started and how it's landed into. Then we come to the past history. And the past history, firstly, we need to know if the child has suffered from any similar kind of illness and has gone through any hospital admissions or has had any other history of illnesses or allergies. So, all this will come under our past history. So, past history, I think we also have to know any other illnesses. Usually, in children, we have to know if there are any febrile seizures or jaundice or any measles, chickenpox, TB, or any other infectious diseases what they would have gone through, and the drug allergies also, not just the food or the exposure allergies, but even the drug allergies come into the past history. Then the most important thing in the pediatric case taking is the birth history. So the child's history starts from day one, not the day when he's born, but the day he was conceived, he or she was conceived. From that day, it becomes important, especially as homeopaths, for us to know in detail what is the history from the conception till the present time when the patient is with you. So we have the antenatal history, that is the duration bit from the conception till the mother goes into the labor, and the perinatal or the natal history, or during the process of parturition, what is the history, we can go into depth of it. And the postnatal is again after the birth, what are the history what we have to know. So let's go in detail of the antenatal. What you will ask your informant or the mother, this history is usually given by the parent himself, or otherwise it's difficult. If the parents are there as the informant, it becomes far more easier for us to analyze the case. So in antenatal history, what do we ask? So firstly, we ask if what is a birth order. Birth order is nothing but which for the mother, if this child is the first one or the second one or the third one. So the birth order of the child becomes important, because if there's any previous LSCS or any complications in the previous pregnancy, which can also be leading to this, that also becomes important. Consanguineous marriage, because we know different kind of genetic problems or cerebral palsy, they have more affinity towards a consanguineous marriage. And also age of mother. Now the higher the age of mother, more prone she is to born a child with probably a syndromic child, like a Down syndrome, for example. Or also the mother's past obstetrics history, that becomes important. How did her previous pregnancy go? That also can give you a clue. Like, for example, the mother who's born hydrocephalus child, so that child can, this child also can have the could have been born, or or you can correlate that there's a tendency for the mother to born a hydrocephalic child. Then comes the fetal movements, is to see how sluggish or active the baby was during the pregnancy. And also maternal illnesses become very important, like eclampsia, preeclampsia, UTI, or any infections like infection, or any radiations, what she was exposed to anything. And Also, even the tetanus injections, what have been given in ANCs, how many ANC visits has she been doing? Has she been regular in the ANC checkups? Has she put on enough weight during that particular period? All this becomes important. It varies from case to case. You not ask from all the cases, but it does vary from case to case how you ask the questions and how much you ask the questions. So, someone asked me, what is a consanguineous marriage? Consanguineous marriage is when they marry within the family. It's very common in India where probably the mother, the girl would marry the mother's brother, or the girl marries her second or first cousin. So I'll tell you the different degrees of consanguinity when it comes to family history, so that it becomes easier, because there are you get for example, like metabolic disorders, or they're all these they are prone to have being seen in a consanguineous married child. So to know if the mother and father were related or not, that is the meaning of consanguineous. And also, as homeopaths, we know that mother's state of mind and the stress levels, what she went through during the antenatal history, becomes very important. How the how she reacted, or how what she went through during that stress period, that also becomes very important for us to analyze the case. For example, if there was a bout of fright during the during the pregnancy, and the child, when born in the initial few months, there's a lasting fright, so things like opium or syphilinum can be helpful in this particular case. So mother's state of mind does reflect what the current or mother, whatever she went through during the pregnancy, does reflect what the child is going through now also. And natal history is when, during the pregnancy, if we need to know if there's a hospital delivery or a home delivery. In India, again, it's nowadays everywhere, like home deliveries are opted, because back in the day it was more like there were unhygienic conditions. If there's any risk for septic, or for a septic shock, so things like that. Or if the labor was on time, if the labor was prolonged, was there any prolonged, or was it premature rupture of membranes? So at that period, did the child go through any kind of reduction in the oxygen levels? Like, for example, in cerebral palsy, initial first breath was not taken, and there's oxygen insufficiency in the first few minutes, or few initial few moments of the child. That has a lasting effect for years together. So that also becomes important in our history taking. And if there's any meconium stain, amniotic fluid, uh, this again, for the respiratory children with recurrent respiratory illnesses, they can have a history of this meconium stain amniotic fluid also. So then we know the cause. That becomes very important, to know the cause. And of course, after the pregnancy is done, after the delivery is done, we know to know that if the child has cried or not. If once the child is cried, did it have a good skin? That's the Apgar score. Did it have a good skin? Did it have good respiration? Did it cry loudly? So all these things become important to know the growth pattern and even the development of the child. And birth weight, obviously, as a pediatrician, birth weight is very important, because we calculate the birth the current weight in correlation with the birth weight. In detail, I will tell you about okay, in detail, I will tell you about the I lost my thread because of the questions. Rashmika, you
No,
said
no, I'm
something.
sorry. I am really sorry for interrupting you.
No problem.
Two things.
Yeah.
First is, if you can't hear her, I'm really sorry. Please refresh your browser. And that's the only problem with browser. This thing, if it's an app, it's not going to be a problem. But if it's a browser, you need to refresh your browser for you to hear her. And the second thing is, if you have any questions during the presentation, you can keep posting the questions, but let us not keep it like it's distracting her. So once the whole webinar ends, the presentation ends, I will keep posting the questions one by one on the main screen so that she can answer your
If I
questions.
if I find some smaller questions related to the particular slide, if I find it
Yes.
kind of easy, I will answer
Yes.
it immediately. No
Yes,
harm
yes,
in
yes.
that.
Yes, yes, yes. Any major questions could be
If
attended after the
the longer
webinar.
questions, I will not answer now. I will answer.
That's not a problem at all. That's not a problem at all. I'm
Done.
really
Done.
sorry for interrupting it.
No problem. No problem. So where was I? I think I was at birth weight. So, in terms of birth weight, it becomes very important for us to know the birth weight, because over a period of time, we analyze a child's growth and how is growing. If the weight is very, appropriate for the particular age group, that also becomes important, because parents come to us when, like, doctor, is the weight all right for his age? Is the height all right for his age? So all that becomes important. And why NICU care also important? Because we know if the child has gone through any physiological jaundice or pathological jaundice or any other initial illnesses that the child have. And also, did the child receive breastfeeding immediately or not? Because we know that colostrum, that is the first milk that comes, is very nutritious for the child, and it builds up the immunity to an extent that it's a very good vaccine for the child. The giving By giving breastfeeding, you're reducing the number of illnesses what a child can go through in his lifetime. So breastfeeding also important to know if the child was started initially the same day, or later on, or why wasn't the child breastfed, and what were the reasons, if there was any suckling difficulty, if the child was not attained the reflexes of suckling, or morose, any reflexes that were needed for the breastfeeding. So that again can hint us towards a delay, or a problem in the nervous system. So things like that. So that this becomes again important for us to ask in the case taking. Then comes the most controversial, that is the immunization. So, if I may ask in the particular chat box, is immunization necessary? Is it needed or no? Because homeopaths always have a parity in this particular thing. So let me see the contestants, participants. What are they? What view do you have? Drop it in the chat box, and probably I can see. So, what do you think? Is immunization needed or not needed? Do we have any answers? Shivraj says no. Ritu says vaccines are not necessary. I think Maria says yes. And baby can get innate immunity from mother, says Shivraj. And Sansriya is saying it should not be made mandatory. Well answered. So I agree with all of y'all. It is a yes and a no, because it is a debatable thing, because since the government has imposed a particular immunization schedule, and that parents are in a fear that if we are going to immunize, and if the child is not going to get admission in particular school, if the booster dose is not given, the he's not allowed in the school. So things like that. This particular decision has to be led to let the parent do the decision for you. You cannot decide for the child. You have to accept however the child has come to you. So if the child is immunized, you cannot say, oh, why did you immunize the child? Or if the child is not immunized, oh, why didn't you immunize the child? So it depends on the parents and how they want to bring up their child. But we also know what are the effects of it, and how it suppresses the particular innate immunity, what you're saying. So also, like I said, things like breastfeeding and the maternal antibodies keep transferring to the child and develop that immunity within them in starting stages. But at least if the parents are confused and ask your opinion, to be on a safer side, you can go for at least the national immunization program. That is a basic program which is made mandatory by India, to be given. and that can be at least advised to the parents. And it becomes important for you as a pediatrician to know what are the kind of vaccinations that are given, so that for me, I'll tell you, because it helps me, because when infants are come after the vaccine is done, they have a lot of fever, or jitteriness, or they get the irritability. All these symptoms come around, and let's say, for example, the chickenpox vaccine is given, which the varicella vaccine is given, and there were some side effects. I would think of the remedy variolinum, or even any other vaccination is giving them any kind of a side effect or a problematic thing. So that time I can think of our remedies like thuja, silesia, or the specific like if you're giving MMR, like morbillinim. These remedies can be thought of to bring out the nullify the side effects of the immunization. So like in our repertoire is given for vaccinosis, like what Burnett calls this situation after vaccination, the kind of symptoms what a body can throw out, he calls it as vaccinosis. And we've seen that a lot of children would have arrested their development, or they might have some developmental delay after vaccinations. So if in case we have something like thuja is a very good remedy, and thuja is very important remedy in post vaccination any problems. So yes, it's common to have fever because the body is reacting to that particular, it's creating antibodies towards it. So there is a reaction. It's nothing but, artificially inflicted disease. So it's nothing but getting infected. So fever is reaction. It is normal. But when there are children who are not able to take it, they're not able to go about it. You're not able to, they undergo a lot of mental or physical problems. The fever doesn't come down even if you put an ibuprofen or a paracetamol. Even if they don't come, think of thuja, or think of the remedy what is apt for the child. Think of a homeopathic remedy, so that that particular state of fever can be helped with our medicine. So that is the thing. Then we'll just move on to what is the most important in a child. So we've so far finished the initial case taking, where we start with the presenting complaint, birth history, past history, immunization history. So what immunization they have done, till where it is done, all that becomes important. And see if there's, like, for example, if I say, if you see the chart, by by the ninth month they get the measles vaccine. So that becomes an important milestone for them also, because once they are exposed to this particular vaccine, some of the children are reacting very how do I say, a very exaggerated way. So some of them opt for the pentavalent. So that also gives them a lot of the MMR vaccine. That also during the 1.5 years of life, they are also start reacting to that particular thing. So for me, it becomes important because I check what was the last vaccination given, and has there been any changes made during that, after that particular milestone in the child, because the prescription becomes easier. So I can start off with an to give up something for the vaccinosis, and then move on to the constitutional, or what is the state remedy of that particular child. So that is why it is important to know the immunization schedule by heart, or at least know what was given to them. Because sometimes parents do not know what was it given. They just say that 6 महीने का 9 महीने का दे दिया, या फिर 2.5 महीने 1.5 years vaccine was given, 9 month vaccine was given. So you should know what is there on 9th month. You should know what is there in 1.5 months. So again, it depends on which part of the world you are in. So in India, this IAP recommendation is what has been followed. So that you can have a look at it, or keep a chart beside you, so that you're not intrigued by it. Then to move on, so as important it gets to know, for us to know the developmental history, because again, we as a pediatrician, the parents are anxious if the child is growing appropriately to that particular child. And as a pediatrician, it becomes important for you to analyze if the child has gone through the normal milestones, what it has to go from, day one till the day they have come to you. So how do we analyze it? It is the gross motor, the fine motor, the social and the adaptive milestones, and the language milestones. So just an overview of what is normal, so that if there is a delay in it, you can make a note of it. You can at least know which domain there's a delay in the developmental milestone. So just to go overview of the gross motor. The gross motor milestone is when the body is slowly starting to develop, where the neurons are getting mature, and there's a more of the quality of the cells are becoming better, and the maturity, the basically the myelination of the cells are becoming, there's a myelination of the cells, neurons, that is going on. That is why after one milestone, there's another milestone. So that is, first one is the neck holding, and if the child is able to hold his neck, and that is done by 4 weeks. And if he's able to pull up and sit, if there's no head lag, by 4 months, the child can start holding the neck. They start having a control over the neck. Otherwise, it just lags back as if in the first picture. And then we have, if the child is able to push up and look forward in the prone position, that becomes also important by 4 months, because his neck holding, when he rolls over, he can look up from the lying down position. And by 6 months, he's able to push and rest the upper body on the arms as well. And by, again, it depends, by 4 months, there is no rounding of the back. That is, again, there is a neck holding that has happened, so the child can straighten the back. And by the month of 6, the child can sit in this tripod position, where the child takes the support of both the hands and sits by their own support. And by 8 months, they are able to sit without any support. And by 9 months, they can start at least standing with support. And then once their first birthday, they are able to start walking, at least take a few steps with some following. So if you have to ask, you can just ask at least when they started sitting, when they started walking, when was the first time they stood up. So these are the milestones which parents do not forget. So to have an overview, when was the first time? Neck holding is very important. So first thing, neck holding, when was it achieved? Then when did the child sit by himself? When did he stand by himself, and with support, without support? And when did he start walking without support also? So it's very easy to remember. It's easy to ask them, by the first birthday, did your child walk? By the first birthday, did the child stand by himself? So that is can be done. So just an overview of it is, by 3 to 4 months, neck holding is okay. By 5th month, the child is rolling over, and by 6th month, the tripod fashion of sitting is taken by the child. By 8th month, without support, he can sit, and 9th month, he can stand with the support. Some children are walking by 9th month nowadays, but ideally, by the first birthday is 12 months, they are able to start walking and stand without support. And by 1.5 year, they're walking alone. They're already going up and down the stairs. And by 2 years, they're walking up and down, and they're exploring new places. And that is why you will have to do all the baby proofing and all these things to take care of the child. And that's how these are till the first second year. If you're able to get these basic milestones, you'll have an idea if the child had a normal development and appropriate timing for that particular milestone. Then we can come to the fine motor development. That is a hand and eye coordination. So if there's a object, if they're able to look at it, or they put it in the mouth, or if they can move it along with it. So all these things can be the fine motor. There's a finer detailing of the development, basically. So the first thing is, the child, if any object is given, he'll hold it with both the hands. So by 4th month, if you can see the child, if something is on the cradle, in the swing, he can hold it by both the hands. That is the immature way of holding it. So they hold with both the hands. And then as time passes, they're able to hold with a single hand. First, by 6 months, there's a palmar grasp, so they take it, completely like this. They will hold something, completely. And then there is, by 8th month, they start, slowly developing with only fingers. That will be more towards ulnar side. So they first start off with ulnar way of holding, and then with over a period of time, by 1 year, they're able to have a mature grasp. So the radial side of it is the mature grasp, and if they're holding with just the index finger and the thumb, that is the pincer grasp. So that's something that comes by the first year, the first birthday, and they're able to pick their food and eat. So that is again hand to mouth coordination. So this is the pincer grasp, which is developed. And over a period of time, they start scribbling. So, they are able to scribble by the end of, 1.5 year. They start scribbling onto the walls and everywhere. So these are the minor thing that the development takes place. So first is the bidextrous reach, that is reaching out with both the hands by 4 months. By 6 months, they're able to, reach with the unidextrous, and they can also transfer the object from one hand to another hand. And then by 9th month, there's an immature pincer grasp. So that is, it will take it with the forefinger. This is an immature, immature one. But once the pincer grasp is taken place, by the first year, with the tip of the finger, they can hold an object. And yeah, by month of 1.5 year to 18 months, they are starting to scribble, and they start making blocks. They can play Lego. They can do the puzzles by themselves. So all this can be done, and this becomes again important in the learning curve. So how much they are able to learn. For example, in the clinic, you can ask them to draw a particular circle, or draw a plus sign, or a cross sign. So you can ask them, see how they are imitating. By 3 to 4 years, they're able to start imitating whatever images you're writing. Then, of course, comes the personal and the social development. So by the 2nd month, the child obviously has a social smile. Like if somebody approaches this child, he will smile spontaneously. And by 3rd month, he's able to recognize the mother, anticipates that feeds are coming. And by 6 months, they realize who is the mother and who are the known people. And when they see a stranger face, they'll have the stranger anxiety, and they do not like it. And by 9th month, they're able to start waving bye and hi, and they can start learning these small things. And by first year, they can either they start recognizing the name as well, and they start playing small simple ball games. So these are the things which you can ask in the clinic. So by 2 years, you can start training the child for the toilet. Okay, and by 2 years, if you see a toddler, they will pull you. They'll try to come and show you things, and they'll ask for food. They know the hunger pangs. And by 3rd year, they know that they are this, but the name is this, the gender is this, and they're able to learn far more things, like shapes, animals, all these things. They can start imitating the animals, the sounds. So these things start developing once they are like 2.5 to 3 years. So having an idea of all this becomes very important to know if there is any delay or precocity in any of this milestones. So last comes the language milestones. That is, first, once the hearing is developed. So once that hearing is developed, when there's a sharp sound, the child might move to that particular sign. And then they start cooing. Once at 3 months or 4 years, they start cooing, and they start having a loud laugh by 4th to 5th month. And by a few months, they can start saying ba, da, ma, pa. All these things are meaningless words. So the 6 months, they are meaningless words, but the 9 months they know that that bisyllable words are mama, baba, dada. So all these things starts coming in, and by the first year they know the meaning of these words. What, like, if they are saying no, they know the meaning of no. If they're saying yes, they know the meaning that they are taking it. Or I want, I don't want. So these things start coming up by 1 to 1.5 years, and the slowly the vocabulary starts building, and from here you can work into teaching them further. So this is how, the starting, if we know a particular in different areas of the development, it becomes easier for us to analyze how the child has grown and if this particular milestone is appropriate for their age or not. So in a case, in a clinic, if even if you cannot remember the whole thing, just remember a few basic things, like the third month is able to reach out to things, fourth month they are rolling over and they're holding their neck up, and by fifth month also they're rolling, and 6 months they're able to say some blah blah words, and by seventh month they are crawling and they're creeping around the area. By eighth month they are able to sit, and by ninth month they're slowly starting to stand and take the support and stand. And by first year, by 11th 12th month, they're saying mama, papa, and they're walking around. So even if you know this much, it becomes easier for you to analyze the growth curve of that particular child. But it's always good to know everything when you are dealing with a pediatric child. So how do we assess this developmental age? So there's a formula which not only a pediatrician might be find important. So developmental age, so we can know what is the developmental age at by knowing all the milestones. So once we know the milestones, we can create an average developmental age than to the chronological age, so what age they are actually at. So that gives us a quotient. If it is less than 70, we can say that there is a slight delay. So this detail is not required, but at least if you know which milestone is there, at particular age group, we can try to analyze it in our clinics. Then it becomes important for us to know the intelligent quotient also. So because how the child can be, if he's able to move further in his prognosis, it becomes important, the mental age and the chronological age. If we find out the IQ, we can know to what level they are able to train themselves. So, for example, between 50 to 70 IQ, there mild mental backwardness where there is a mental retardation where they can be educable with some special skills, and if it is 35 to 50, they're trainable and in some workshop setting under some kind of monitoring. And to 20 to 35 IQ, they need they can be trainable only for the self-care need, but they still need some help from the outside. And below 20 IQ, there's a profound mental retardation and they need custodian care. So these things all help us to see where the child lies. And even when we start treatment, we know that if there's any progress in the IQ, this becomes also very important. So if we analyze the case and know what is normal and what is deviated from the normal, it becomes it becomes easier for us to even prescribe and educate the parent. If they need to take extra therapies, or along with homeopathy they need to go for extra therapies like speech therapy, hearing therapy, or physio. All these things becomes very important. So in homeopathic treatment, we can, if we go into the repertory, we know that we have so many remedies for development when it's arrested. Many of the minerals come in, and thyroidinum comes actually one of the very good remedies, and they have seen to have a good results with thyroidinum also. And also we have like rubrics where there are slow to talk, slow to walk. So the learning curve, our medicines also help out in making the learning curve a little better than what they are going through. So again, minerals here are very important, and we know that talking's slow, late to talk. One natramur is one of the more key remedies, and delayed in walking. The calcarea group of remedies, the carbon group of remedies are again come out very prominent. So having said that, that is the developmental part of it. That is the quality, the maturation of it. So now what about the quantity? We know the child grows from a day one to the to the adult size. So we have a period of a growth that we have to monitor. So that comes where we come to the anthropometric measurement. So that is when we have to go through the weight or height and the head circumference, chest circumference, mid-arm circumference, all these things, and the dentition. These things are, analyzed and managed or studied in a more measurement basis. So these are the things which we can tabulate in our clinic while the case has been taken. So, if we say start off with the weight, now the weight we know, if in an average Indian baby, the birth weight is usually 3 kgs. It doubles up in 6 months and it triples by the first year, and it quadruples in the second year, and then third and the fourth year it goes on. So for the weight, the expected weight can be measured, as per their weight. So at 5 years, we can multiply their birth weight with 6, and at 7th year they can multiply. I think this is 5, and by 7th year the birth weight is multiplied by 7, and by the 10th year it is multiplied by 10. So this way we can find out what is the expected weight of that particular child. Just a moment. So, on an average, a child gains about 2 kgs every year between the ages 3 to 7 years, and 3 kgs per year after that till the pubertal growth. So, then there's a spurt that happens in the pubertal growth. Now, what about the height? The height also, if an average Indian baby, if it is 50 centimeter, and then it increases slowly by 5 to 10 centimeters depending on the constitution and the familial inheritance, and then it becomes slowly graduates. So we can find out the target height of the child by a simple formula which says for boys, which is different for the boys and the girls. So the father's height plus mother's height divided by 2 into plus 6.5 for boys and minus 6.5 for girls. So this way, this becomes important because I have felt that in my clinic, a lot of patients want medicine for doctor, please give me medicine where the child can grow in height. Like I want him to be tall and things like that. So we need to know if the particular constitution allows him to grow exponentially as how the parents want them to grow. So a useful guide for normal height would be plus 7 centimeters for girls, and target height is plus 8.6 centimeter for the boys. Next important measurement is the head circumference, which is very commonly seen in pediatric OPDs where the newborns are there, where the head growth is very rapid initially, because the brain development is taking place in the first year because by the second year of life the child's brain is growing almost to an adult size, and that is why the brain growth is reflected here. So it's important to know the head circumference size. And also the frontal closure. So at birth, the anterior and the posterior frontal are usually open or the present, and the posterior closes very early. A few weeks of age, the posterior frontal starts closing, and the anterior frontal normally closes only by the first year or the 1.5 year of age. So this is still more sensitive and open. So if in case there is an early closure of frontinals, it indicates that this craniosynostosis, it's a condition where there is a premature closure of the skull sutures. This again important because this restricts the growth of the brain. So again, when there are different kinds of anomalies or mental retardation or central nervous system disorders, we can suspect if the proper brain growth is not occurred because of early closure of the front fingers. Then comes the chest circumference. We can correspond this with the head circumference. So it's usually about 3 centimeters lesser than the head circumference at the birth, and the head circumference and the chest circumference become almost equal at the first year, and then it always exceeds the head circumference. The next best important thing in the clinic is the BMI, because every mother and father, they do want to know if the child is appropriately, if their height and the weight is normal for their age. So so if there's a BMI more than 30, we can think about obesity. If there's less than 15, this again can give us a hint if there's any malnutrition. So this measurement also becomes important. So this an overview, if you know that more than 30 is towards obesity, or more than 25, 26 is the overweight, where the child can go into child obesity, and less than 18, the child can go under malnourishment. So we know the formula for BMI, weight in kg by height in meter square. So that is the normal thing what we follow to calculate the BMI. The next important thing is a dentition. To know at least when was the first tooth erupted will become important, because nowadays I am getting more cases where the dentition is getting delayed. Probably I got a few cases where the growth, the gross motor development, all the development, developmental domains are normal, but there's a delay in the dentition. So the first tooth to erupt is usually the mandibular central incisor. So once that is the first one, at 5th to 7th month approximately, the child will start, getting this primary teeth, the first tooth. And obviously, this again, the parents do remember, and that if there's a delay or not delay in this. So the central incisors by 5th to 7th month, and then we can get the maxillary one. Then slowly we get the lateral incisors by less than a year, and by 1.5 years they start developing the canines, and the first molar they have it during the 1.5 years of life. So again, why I tell you about the gestational problems, because the gross motor or the global development can be normal, but still the child can have developmental problems. And then dentitional problems, we know that it can be not just slow to erupt, but also when there are dentitional diarrheas, dentitional irritabilities, and the pain, the chewing, the salivation, all these things can be one of the presenting complaint what the parent can come to you. So you need to know if it is a normal period where the child is going through dentitional period, and that is why he is facing all of these issues. So that is why it is important for us to know the normal timing of the tooth to erupt. So the next thing in the main, if we have not missed, that is the nutrition. Nutrition of the child is utmost important, because in children, the minutest of minutest changes in the diet can bring out any abnormalities, and it becomes important in our case taking, because especially if there's any change in the diet before the illness. So diet before the illness, if it was normal, and during the illness the child wants something else, or the cravings are something new during the illness, or what is the daily food intake. For example, like if the child has not been given a good amount of fruits and vegetables, and just been fed on only rice and dal and only carbohydrates or only protein, the child might have certain vitamin deficiencies like scurvy, and the bones can get a bit brittle. So that is why good to know what the food they are having in a day-to-day basis, that becomes important. And breastfeeding, if it was initiated, and how long was the breastfeeding done. Some parents discontinue immediately after weaning, and that is not something you need to advise. At least to 1.5 year they can continue breastfeeding, which is very important for the child and for the bond what the parents go through, mother and the child go through. And when they're weaning, when they're starting the complementary food from the 6th month, what did they start? Was there any difficulty? Was it that this illness started from that particular weaning period, or was it a formula milk that was given the child couldn't tolerate, or any changes in the bowel habits since the new food substance was given to the child? And again, if the diet I told you about, if the diet doesn't contain a particular vitamin or iron or calcium, that becomes important. And food allergies and intolerance. Some children nowadays are not tolerant towards, let's say, milk products, or not tolerant towards any citrus fruit. So these things can give a hint towards a remedy also, and to know the underlying disorder in the child. Then comes one of the most important in not just for us. Generally, it's good to know the family history so that we can rule out any abnormal diseases what the child is going through. So one thing, I've spoken to you about birth order and the age of parents, and illness of the siblings. So if the mother has born children who have died earlier, because if to suspect any metabolic disorders or any syndromic child, you can suspect if there's any illness in the same kind of illness in the sibling, or it's same kind of illnesses are there in the child who was the lost by the mother. Then again comes the consanguinity. This is the thing what I was trying to tell you by what I meant by consanguinous. If the parents are married within the family, so the different degrees of family, we usually don't see the first degree, but the second degree is the aunt and the niece, or the aunt and the nephew and uncle and the niece, or even half siblings. And the third degree is the first cousins, and the fourth degree is a distant relative. So the most risk group would be the first, second, and third. Distant relative, not so much. So that is how we that is why we need to know the consanguinity if the parents have been married into the relation. So, what is the homeopathic approach? Basically, all of this is important, in the case, and need not be necessary that you follow this particular order. It can go in from anywhere. So, as a homeopath, I think we generally avoid all of these things. What is there to be done? What is necessary to do also, and we only focus on the personal history or the mental history or the emotional history, and forget about the kind of importance we need to give towards their developmental or the nutrition, or family or the past history, because it does hint us the kind of things they're inheriting, the miasm what they can be at. So all of this is important, along with whatever we ought to do as homeopaths. So as homeopaths, I think it's very important. Like I said, the first things first is to be an unprejudiced observer, and observations are one of the. I mean, if I would say that if with a newborn child, there's maximum, it's only observations and examination of what you can do for the child. But over a period of time, when the child is developing his own personality, you can start having more symptoms and more cooperation with the child also. So when we start having that cooperation with the child is when you can start engaging the child. So what do you mean by engagement? Start engaging the child with some kind of activity, or a doodle, or trying to keep some papers in your clinic where they can write something for you. Or probably it helps, because if the child is having some kind of dyslexia, we know if there's any changes in the words. If he's writing B for D and D for B and P for Q and Q for P, so these things also help. And again, if they are able to draw a picture, they can tell you the state what they are going through, and depict a story. All these things are ways you can start engaging the child. And obviously, we have to go to the child's sensitivity, find out a characteristic symptom which will help us to give us the particular simillimum what the child requires. and the exciting factors what the child is usually prone to be excited towards, and obviously mother's history during pregnancy. That is the key factor. These are an overview of what we as homeopaths should also include apart from what we have seen in the last few slides. So observation starts from the clinic, from not just from the consultation room, but even in the waiting room, how the child is. Excuse me. Yeah. So observation, the child, you can start observing the child from the waiting area. Some doctors also have cameras in the waiting area when they're not accessible to it, so that they see the child how they are behaving in the waiting area. Are they restless? Are they, how are they behaving with other children? How are they behaving with the toys that is kept around? How are they, are they, pestering the mother, or who are they clinging on to? All these things start becoming a hint towards the remedy, a hint towards to know the child in depth in their particular pattern. So, for example, like if I may say, there was a child when he was sitting in the waiting room, and he couldn't even keep his head up. He came to me in fever, and all he did was lie inside the mother's arms so much that he didn't want to put his head up also. So that was the thing I observed in the waiting room. But once they came in, I inquired further. Why is he sleeping this way? Why is he, want to go inside you so much that is he tired? Is he drowsy? So that gives a clue. Turns out he was so sensitive towards light, and that is why he was trying to hide himself and not see the light. So again, when the mother also had to observe that once he's in a darker room he felt better, but once I put on the light he couldn't do it, and that fever was in a particular characteristic way, and he did well on delcimium. So uh, apart from that, other observations, like you can also see how the nature and the disposition of the child is. If the child is talkative, if the child is very notorious, if the child is restless. So for example, sulfur is very inquisitive. He wants to just touch, like if he goes to different places, he wants to just touch everywhere, and that is the it impels him to touch because of his curiosity. It doesn't mean that he wants to destroy the particular product, but he just has to touch everything. So things as you can start observing in the clinic. And also, like for example, tuberculinum, he's so restless. He's not there. He's busy with himself. Something is keeping him restless. And for if you look at tarantula is restless because he's notorious. He might want to do something. He can be a bit cunning to do something. For example, there's this rubric called striking in children, and especially when they're not being seen, tarantula comes in. So I remember this case where we had in our college we had OPD, which was inside, and the waiting chairs was little outside. So by the time we were almost finishing the cases and going, this child saw that the parents are still inside, but he quickly went inside. Outside there was another child sitting there. He just for no reason went and hit that child, and he came back in and he started laughing. So these kind of things, it's good to observe in that particular thing. So that was just out of his notorious behavior and cunningness, or he just wants to, he's impelled to do something to harm, inciting others, if you can say. These are the rubrics you can think of. It need not be the short, but at least if you observe, you can try to analyze it during a repertization and the remedy selection. So an example again, like striking in children, like what I said. And the chamomilla, they strike because they are in pain and they cry out so loudly. So these again are the observations what you can start seeing in the patient. And clinging on is another something very important, because different remedies cling on to the different things. Like for example, stramonium, they cling on to the furniture, they scream in their whole they startle in the sleep, they scream, and they cling on to whatever's near to them. So whatever furniture is near to them, or the mother is near to them, so they start clinging on to that. So, and for example, so different pulsatilla is clinging on for the care and the affection or the fear. So again, different remedies have the different need for their clinging on. And we know that restlessness, if you see, so I have a lot of toys in my before corona times, I used to keep a lot of toys on my desk. So I could see that, that's how I learned this rubric also. Like, the child was not happy with one toy. Like, this toy is done, okay, done, next one. Then I'm bored with this, next one, then I'm bored with this, next one. So he keeps moving on from one toy to another. And for that child, it was an bedwetting case. And he did wonderfully on tuberculinum, because whole remedy, the whole family history, everything came across very well to the tubercular miasm also. And he did very well with this tuberculinum. So things like this we can start observing from our before even we start asking any questions, we can start observing the child at their face value. We can also observe the precocity. Like for example, if the child is talking more than for his age. For example, if they're talking like a big elderly woman or an elderly man, more than what more mature than what they are of their age. So at that time we can think of carcinosin or Merck. So precocity also can be an observation that you can create after the case taking has been, or during the case taking, on how you observe the child speaking to the particular mother, or to the other people. So these are the observations what you can do. Or for example, phosphorus. If the phosphorus child can be more communicative. So if it's a phosphorus child, you don't even have to rely on the parent to tell the case. The child can tell everything according to what whatever her likes are, whatever her dislikes are. She can tell it to you, directly to you. So they are communicated that way. That becomes again a key feature for your prescription. Apart from that, we can also think about like I said, if you have papers and if you ask them to write, you can this again from the parent or from you see in the clinic. You can see that they cannot learn easily. They cannot think of the particular remedy, think of the particular word that they want to see, the letter they want to use, like lycopodium. Or for example, stammering. If the child is stammering also, we can think of stramonium at that moment. So things like that we can start observing from that particular from the moment the child has entered the clinic. And what I was talking to you about engagement is that I usually have plain paper, prescription pads, because everything is digitalized. The prescription pads are basically used by the children to start having, some kind of drawing. So I keep some kind of, color pens and all these markers, so that they can throw their imagination to anything. And so there was this child, who had this. He drew a very nice image, and he actually narrated the whole story. So that is when it becomes easier for us. This doodle can help you go into the inner state of that particular child and understand the sensitivity of the child, or what the child needs himself. So this particular child, he could picturize a whole situation. It was a scene. He was almost like 5.5 years, I'm sorry, 7.5 years old. And he drew a scene of, there's an ambulance, there's a fire that's going on, there is some people are wounded, and then the police is coming in, and the whole thing, there were different parts in that particular doodle, that I asked him, what is this, can you tell me the story behind it? And that's when he started telling in that his need to help people, the need to go. He is in the ambulance. He wants to be the policeman. He wants to go and help them. He has to take the responsibility of helping people. So when I inquired further with the mother, she also said that he has this interest towards ambulance and helping and police, and that started giving a hint towards I would ask why, and we go in more deeper into the case and try to understand the whole pattern. And that child actually did very well on Nicolin, so it was a very nice case, in fact. So next up would be the sensitivity. We know that every child sensitive, something to danger they are scared of. Like if they are scared, they're sensitive to others' opinion. They're sensitive to rudeness. So different child has their different sensitivity towards a particular thing, and they have a different reaction. Like for example, like belladonna can run away from escape from the particular situation. If this was a belladonna, he would be running away from a particular situation in fright. And things like fears can be taken care of. So sensitivity in children, like for noise also, like light, like previous case I told you about. So like light, by noise, or sensitive to a draft of air, and or even when somebody is reprimanding them, or blaming them for something what they've not done, and they fall into some particular thing. So that also becomes their sensitivity. And like I told you, rudeness also. Here I wanted to share one case of a small girl. Like she was just 5 years old, and they had an uncle who came to visit them, and this uncle was going through a rough patch. And after this child was she was very bold and very mature, and this uncle ended up shouting at her and just be a bit rude to her. When she went to show a toy to him, he just trying to like shoo her away. And after that, she developed a bout of cough and fever that wasn't going. I was trying with different remedies like Ars or Drosera, but this particular situation was not told to me by mother. Then I asked deeper, and it was not helping. The remedy is not helping. And the mother told me that if the uncle would have shooed her away and not given her anything about in front of without people around, she would have just been fine. But she felt a bit she couldn't take his rudeness, and she ended up in this she felt bad, and she walked away in a very embarrassed kind of situation. So after that, this is the fever and the cough had developed, and she did so well on staff, and just a single dose was enough for her to come out of that. And because it was more like there are different other factors like her anger. So usually what is going, she comes out, wasn't coming out. So many other symptoms. So this is one of the things where we can think of in the case taking, where we could have missed it, but that became an important point for our remedy selection. So that is again something what we need to think of. So usually I ask my patients' parents, like, what are you sensitive towards? So this is an open question, like what are you sensitive towards? Some people take it up, they think of what they're sensitive first. So some people might think that a draft of air, or a cold, or AC, or or they might think that if a punishment or something. So whatever they are sensitive to, it will come up first. So usually I don't ask them if is she sensitive to cold, is she sensitive to hot. I just put an open question, what are you sensitive to? So that's when we get our characteristic symptoms, so that we can go in deeper from there. So that is just try to give open questions to the child, what they like, what they don't like. So things like that becomes very easier for them to flow through. So need not be a particular way to do it. So sometimes what I do is I just ask them how their day was, and I ask them like how is school and what is the new thing that is happening in school. So they would that's when they would open up sometimes, about somebody bullying them or something that they're enjoying, or anything. So this is an open if you have open ended conversation with the child, you can go into different areas where you wouldn't have got in with your leading questions. So that is something what you can start practicing, and then eventually get there, and you can develop your own style onto how to get that particular case. So ultimately what do we want in a case is that we need a characteristic symptom. So you can go into the personal history of it or the mental journal. It can be there anywhere. So do not forget to take your personal history, that is your appetite, hunger, sleep, dreams, and I also forgot that dreams are very very important in the child, because even if the child because the child is the only person can tell you about the dream. So probably after 5-6 years they're able to narrate their dream. So even if you ask them what do you like the most, what do you want to do, so they might give you the hint of their inner patterns, what they're going through. So dreams are something which is very important in this particular case. Then obviously the physical aspect of it, there is the sweat, and how what they like to eat, what are their cravings, what are their aversions, and thermals as well, how what whether they are reacting towards. And also examination part of it, when I usually look into the different parts of the body, even if it is an infant, see the different parts of the body, especially in a fever situation. If the hands are cold, head is hot, hands are hot, feet are cold. So there are different ways. Again, not having a bias that like the usually we have a lot of anxious parents that even in a hot summer, they if they are feeling cold, they will put the baby with a lot of warmers and socks and mittens and everything. So because they are feeling cold, the child might not be feeling cold, and that's when the body temperature can be higher than what is normal. So here you have to have an open mind towards the child. So again, you have to be a judge, a lawyer, and a detective into different aspects, even how the parents can be with you, with the child, and what the child's sensitivity and cravings can be. So if it is a older child after 5 years, he's able to express. But what about the ones which are brought up by the sensitivity of the parents? So that becomes the actual challenge where you can face in the case taking. So once that is done, we have the most important, that is the mother's history during pregnancy. This the common questions I've just jotted down, because most of us want to know what questions to ask during that period. So firstly, like I told you earlier, only what is the history of pregnancy? If there's any antenatal problems that the mother went through, state of mind. What you can just ask the mother, how was your state of mind during that pregnancy? Or what were the new cravings, or what were the cravings you had different in this pregnancy than the previous pregnancy? So usually two pregnancies are not the same, like two children are not the same. So again, the two pregnancies are not the same in the child. So the cravings also change. So sometimes the mother has more affinity towards heat weather. The mother's craving more sweets in this pregnancy. The mother's craving more sour in the other pregnancy. So that becomes characteristic for us also. And the physical symptoms or any particulars, if she have a lot of vomiting during pregnancy where it went on and on for months together, was she deprived of particular food or anything that she couldn't tolerate, or intolerance during that pregnancy time. And there were also what were the dreams during pregnancy, that shows the inner state of what the mother went through during that particular period. And also the life situation, so a situation what she was in, and then how it stressed her and how she reacted towards it. And that becomes very important. It is extremely important for to know the history of the child. So having said that, then we also have to go into the different areas of interest, like so I have toys of different genres. Like I have like few cars, one, a dinosaur, a jingle, or something which makes sound, something which has wheels. So different types of things the child likes. So you can think or ask the parent what kind of area he is interested in. So next is the fears. Fears are also very important because again shows the inner state. Fear of the dark, fear of examination, fear of ghost, fear of anticipation to a particular exam, or fear of strangers. They have new guests at home and they start having issues. So all these can also go into the deeper level of that child. So just you just have to be there and let the child talk. So here today, I like how I am asking so many questions. This is not even like one person. We as physicians should talk. So at that moment when the child is in front of you, you just let the child talk or the mother talk. Especially when the child is a little bit older, it becomes very interesting. And as a pediatrician, it's really nice to see the naive, or the it's unfiltered. They have they can tell you things whatever they feel at the face value, and it becomes actually very easier for you to analyze without theorizing a lot of things. Theorizing any, you need not theorize anything. Whatever comes to you face value, you can just analyze and understand it with the Metina Medica and the repertoire languages, and just go with the flow is something which we all can do, not just in the pediatric case taking but also in the adult case taking. I think letting the person talk, letting the child talk, or letting him be however he is, like even if he's being notorious, he's trying to take things from your desk, he's trying to throw things from the other side, observe. Whatever it is, observe, unless you have something very expensive. But do not keep, if you have only patience, do not keep anything expensive on your desk. So let the child just play, have a playground in your clinic, so that you can observe the inner state of that particular child, and uh, have your analysis done very easily. So to conclude, I can say that enjoy the process, enjoy the whole case taking process, and trust in it. Like you don't have to dig in with the different theories and all. What can it be, how it can it be, like he's dreaming this because probably he went through that. So don't think of anything, just go into the state. Whatever the child is saying, take it as a face value, see what are the different observations and state of mind what the child is going through. And I think learning from everywhere is something what you should do. There are different methods of case taking. This is just the start of it. And since every child is unique, every case taking also is unique. Sometimes you need some the help of the mother, sometimes you don't need help of the mother. Sometimes the mother wants the child to speak alone. So all of these things can teach us, even the patient can teach us how to take that particular case. So we have an open mind, learn from everywhere, and that is something what we can do uh, by the end of it. So if you have any questions, you want to take it now, or you can ask me wherever. I'm open to it.
Hello, hi. That was a wonderful webinar. Actually, I was, very nervous and scared that I was scared that, you prepared so, you put in all your effort to prepare 71 slides, and, I was very scared that 1 hour is not enough. But I'm very happy that people were, glued to their seat and, listening to each and every
I hope they were
information.
there. Nobody slept. No.
No, it was such an amazing. I think such detail, such everything from the basic. It's very difficult to have people talk about it, and even for doctors who are practicing, it's very important for them to brush this phase.
Definitely. And I think it becomes very important because, patients, parents, I mean, the parents come with, the thought process that, we're giving everything to you. Sometimes patients don't want to go to an allopathic doctor and they want to take
Yes.
only homeopathic treatment. At that
Yes.
moment, you cannot be like, Acha, you go to that allopathic doctor, see if your growth and development is normal, and then you come back to me.
You
No,
can't do that.
you have to be equipped with everything what we can. So that is the whole idea of even me taking this particular lecture also, because I want the final years and the interns to take the case in so much depth, so that once they are in the clinic, they gain that kind of respect as homeopaths. And over a period of time, homeopathy is developing in a way that
Definitely.
homeopathy starts getting that respect. So the respect comes from the physician. If the physician is not respected, the system is not respected. So that was the whole idea, and I thoroughly enjoy talking anything about pediatrics.
That is lovely. That shows how much of love and affection you have towards kids. It's so nice to have such doctors, and I that is one part where I enjoyed the process of homeopathy, because or case taking, because you usually go to a clinic and the doctor doesn't give you more than 10-15 minutes, and you feel bad. Like you'll be you come out and be like, oh, I should have told this, I wanted more time to tell this, and you feel bad. And such times, such doctors, you get, I got inspired from my homeopath who I was going to when I was a kid, and that is why I joined homeopathy, and I
That's
think that
wonderful.
truly reflects.
That is really wonderful. And I
uh,
think the whole process also is something which is healing, no? Once the child is talking, he's able to, be aware of that particular state he is in, and something nobody has asked him, or, something, you're giving a place for him to open up without any judgments. And I think
Without any doubt.
sometimes children just want that, space, because parents can be too, dominant over them, and the children might feel so submissive and not open up to the parents so much. So I have children who can talk to, just a moment.
Yeah, sure. Uh, Till then, I'll address everyone. If you
It's
can, please take note of Dr. Sheetal's email ID for any other queries and any other inquiries. Till then, I'll open the question and answer section so that we
sure,
can
sure,
answer
sure,
down
sure.
your questions.
Done.
Plus, that is the one time where patients, I mean, the kids will have the time with, especially this time, post Corona, I'm talking about, all the parents would
Definitely.
be out for work, and at least one particular time where it is somewhere or the other, it is a bonding for the child, for to go out with the parent. And sometimes I feel very bad that some parents just send the kid through an attendant or something like that. I
Yeah,
feel
but
very
that
bad.
is again
We,
something, a
we as a
limitation,
doctor
no?
can't converse with the parent also.
Also,
That's
I have seen that parents, since parents do not have time to spend with them, so especially when I was in college, I would see that the children used to come in with their grandparents or their nanny, because they know more than the parents themselves. So
yes,
again, that's why the process of informant is very important,
yes,
because you don't know who's taking care of the child. The parents
yes.
don't know about the child nowadays, unless they're actually spending so much time with them. But thankfully, because of Corona, I'm seeing my
I
paradigm shift in the children's health, because the parents are right there talking to
right
them and
there.
being there with them. No, so that is something which I'm seeing a positive change in my patients also.
That's very lovely, but I hope that continues, post Corona
Definitely, I think
also. I
I
really
make
hope
them
that
aware of it
continues.
also, and I
Or
tell
else
them
the
that.
child would start longing for that, post Corona, the normalization gets happened, the child or the parents go back to their routine, the child will start longing. I'll start posting questions one by one because it's getting
Done,
really
done,
late.
done.
The first
What a
question:
big.
what should the major points for going in case taking in 2-3 months old infants? I think
So,
she's
firstly, since I have not covered this in this particular lecture, because it go far too deeper. If it is a neonate, like from the first day till let's say 5 months, you have to analyze the reflexes. If you could go through some of the basic reflexes, that will be one of the things which you have to look for physically. Like for example, the Moro's reflex is something. It's something very just a moment. Yeah, so that's something very inborn, and starts in the second and third month. And even the suckling reflex. Suckling reflex is something that has to come from the first day onwards, 36th month. And the second to third month, how they are, responding with the parent, and how they are, especially you just have to take care of the bowels, the urination, and the sleep. That becomes very, very important. I think I've missed out covering that part somewhere. I'm so sorry about it. So sleep, bowels, and urination becomes very important. Because in a 2 to 3 month-year-old infant, you need to know at least they're sleeping 18 to 20 hours a day. So if they're not getting that much amount of sleep, it's very disturbing. And also the adequate, again, nutrition becomes very important. Proper exclusive breastfeeding is something what you have to advocate as a patient, as a doctor. And that is something you have to take care of. Like no extra, not even water was supposed to be given. Only exclusive breast milk has to be administered. Then again, if there's a fever or acute during the second or third month, what can give you the hints towards the remedy is that, again, how the child is responding to covering. If they want it to be, they usually wrap the child up, right? So if during the wrap child, they start crying. If you put on the fan, they feel better. Once they remove the cap, they feel better. So things like that, observations again start becoming better. So again, if that particular period the lips are dry, if the lips are not hydrated enough, or it is too red, things like that. Or like say if the child is having a diarrhea, so then you pinch the abdomen and see if there's a lot of dehydration. So things like that, all these are the observatory things what you have to go in that particular age. So neonate case taking is again in depth. So with the reflexes and different examinations and how the child is lying. In fact, even that can give you a hint. How is the posture if it is lying? Usually the legs are up and the hands are up. If there's total flaccidity, all these things can hint towards the disease and the remedy also.
The next question, two people have asked the similar question, how to repertorize mother's rubric in child? And the similar question is, how are we to correlate mother's state in pregnancy to the child's condition?
So you need not actually repertorize every single thing in a case. So that is one thing I think I want to tell my final years or students who are up here. So you need not take every single aspect of it. So you need to think, like for example, mother's state. Let's say the state during the pregnancy was of, let's say, insult. Along. Let me just take an example of insult that was there for it so much. Okay, and if that state is carried on to the child, if it is the child is going through a particular issue, let's say a learning difficulty or a school adaptation problem, all those things, if it is actually impacting him, then that correlation becomes an important factor. So you can think of remedies which are have that need to have their self-esteem, who are sensitive to insults, are sensitive to when their honor is wounded. So things like that can be there in the back of your head. You need not actually put it in a repertory sheet, but you should also have it. If it is short, let's say, for example, let's say the child you're taking in the first month itself, and you know that during the last 3 months this was what she felt, and now the child is going through let's say genetic problem, or a bowel issue, or like a megacolon, or any issue. So at that moment, directly you don't even have to repertorize a child's case. You take the state what the mother was going through, exactly the same thing, you can give the remedy, and it works. It really it solves a lot of problems during that time. So the moral of the story is not to consider everything for repertorization, but consider it for the remedy selection. That is what is important. So, for example, I gave you an example of opium. A long, stated, how do I say, the fear what was there during the state. Usually, there's abuse and things like that. The mother gets too, into the fearful stage, and the same thing carries forward to the child also. That becomes again important. Also, there's another, interesting way of applying this. Like I applied for one of my patients. The child was complaining of sleeplessness, and so much sleeplessness that it's a 1 month old child, 2 month old child. There's no sleep at all. The child is not sleeping less than 10 hours. When the child has to sleep for 15 to 18 hours, the child is sleeping for 10 hours. And I saw that even the mother during the pregnancy had this sleeplessness so prominent that, and that in turn, and that's when I applied it and I gave the child syphilinum, and it worked amazing. It was like immediately it was better than any antidepressant or narcotic like sort of a thing. So it's again your own skill. You can develop your own skill how you want to do it, but keep it in the mind, keep it behind your head that you have to correlate it. You have to keep it somewhere in your analysis. It need not be in repertorization. You can take it honor wounded in your repertorization, let's say, or fright remaining. You can take it like that, or probably how do I say, reproaches, ailments from things like that. You can start taking in your repertorization if it is short. But for example, if a child is coming to you with fever, cold, cough, okay, since 15 days and no other previous bout, all this doesn't matter. So if the child is more than 5 years and there's no that long-standing issues, if there's any acute issues, at that moment, please don't sit and take your mother's history of pregnancy. It's an acute, take an acute, and give them an acute remedy. But if it's a chronic problem where the child is going through for days together, I'm so sorry, days together, so that is when you have to take every aspect of what I spoke today in your, repertorization or case analysis, everything.
Very true. We are leading the exceeding the time limit. Are you okay with it?
Oh my
Just
God,
one last question. Yeah, one last question and we'll end the
one
session.
last question and then we'll, get it done.
Yeah. Everyone's sending thank you. Thank you so much.
Done. Then we will close it because even if I
Yes,
talk,
yes,
I keep
definitely,
talking. I don't see the time.
Definitely, 100%. It's very late. Yeah, I'll just put the ending slide and we can close it. Thank you so much, everyone, for joining us today. It's been a huge pleasure to have her. Really sorry. Yeah. Can you see the slide?
What slide?
Oh, 1 second. I am trying to share the screen.
You can close this, no?
Then that's fine. It's fine. It's fine. It's absolutely fine. Can you see now?
It's loading.
Thank you so much, everyone, for joining. It's been a pleasure. Thank you so much, Doctor. It's been a huge pleasure. I hope we work more on, the same platform. We collaborate more and work more and give us more seminars. And one more query everyone's asking is, I know you would have missed 2 minutes or 3 minutes during the webinar. So we will be definitely posting the webinar in our I Love Homeopathy platform. So once it's uploaded, you can all go and watch it again. If you've missed any few minutes, you can always go and rebrush it in www.ilovehomeopathy. Yeah, I have just
Wonderful.
posted this thing. You can all take it.
Wonderful, wonderful.
And anything and everything you can do, go and directly contact Dr. Sheetal. Thank you
Definitely,
so
you
much.
can contact me wherever I am. You can contact me or write to me how this. I think I would want to know how is the feedback of this particular
Yes, yes,
webinar, so that I can improve in my further webinars. If there are any opportunities given by I Love Homeopathy, so let me know how this particular webinar went for you. What did you learn? And if you have any doubts, you can email me or Instagram me or Twitter, anywhere you can find me, you can get hold of me. No problem.
Thank you so much. With this, we'll
Thank you,
close the
Dr.
video.
Rashmika.
Thank you so much, everyone, for joining us today. Good night and have a sweet week.
Good night, everyone.
Good
Thanks for
night.
joining.